Sikeleli Afrika malupagani supondolwayo izwa imithandazo yethu Kosi sikelela thina lusapho lwayo Murena buluka sechaba sa Yesu Ufedise dintwale matwenye Sibuluke sichaba sa Yesu sichaba sa South Africa.
South Africa, a diverse country with a population of 56 million. 7 million of them have HIV, which is 12.7%. In 2016, the South African government took a big step by making the treatment of HIV and AIDS accessible for everyone. The government has created some awareness of HIV and AIDS.
What I know about AIDS, it's not a really threatening, killing disease. If you took your medication treatment thoroughly, that one I do understand, but it strains your mind. Just having the disease, it can change everything.
If left untreated, eventually HIV will lead to AIDS. This is determined by the CD4 cell count in the patient. CD4 cells are part of the immune system. The HIV virus kills the CD4 cells. If the patient has a low CD4 cell count, the immune system is weak, so there's a higher risk of developing a so-called opportunistic infection. These infections cause a wide variety of symptoms and complaints, which affect the life of a patient severely and may lead to death. So what the treatment does is it prevents the virus from killing the CD4 cells. But starting with treatment can lead to complications. One of these complications is IRIS, Polokwane Provincial Hospital. This hospital plays a central role in the healthcare of Limpopo province. In their internal medicine department, IRIS is seen very often. Professor Ratsela is the head of this department.
Well, IRIS this is the abbreviation for immune reconstitution syndrome. And the pathophysiology of IRIS encompasses the factors of the immune system which get more accelerated, more activated when you start on giving ARVs, in other words, antiretroviral treatment in a patient who has HIV. In other words, it's just the escalation of the immune system, which gets to be more vicious to the body, and the patient gets more sick than he was before.
Symptoms of IRIS depend on the underlying opportunistic infection. The patient can present with worse symptoms than before or other symptoms than before. But also, patients without symptoms of the opportunistic infection can suddenly present with symptoms after starting treatment.
As for the time of presentation of IRIS, we guess that most patients with IRIS can get IRIS from 1 week after treatment up to 6 months. The worst risk factor of IRIS is basically the immune system, which is very depressed. In other words, if you have a patient with a CD4 cell count of 50 or 100 or less, that patient is more likely to have IRIS. And if you compare patients with a CD4 cell count around 200 are not so much exposed to IRIS as opposed to patients with a CD4 cell count of less than 100, and less than 50, and so on. So the lower the CD4 cell count, the more risky it is for a patient to have iris. And that's why when we meet patients with iris, with HIV, if the CD4 cell count is quite low, we don't start them on treatment, but we treat the opportunistic infection first, and then we can go on and treat the HIV. In other words, start on ARVs because of this high risk of iris in patients who have low CD4 cell count. Iris is quite common in South Africa, and then we understand why. The reason why it's common here is because we have a lot of TB, we have a lot of HIV. Actually, primarily HIV. We have a lot of HIV in the country, so we tend to have a lot of patients coming to our hospitals, to our clinics with HIV. And among those patients, we have patients with a very low CD4 cell count. And once you have a low CD4 cell count, you tend to have iris. And that's why we have a lot of iris in South Africa. Well, iris, it should be understood that it's not only related to TB, but there are other opportunistic infections like cryptococcal meningitis, Mycobacterium avium complex, toxoplasmosis, and you can have cytomegalovirus, and a lot of opportunistic infections, and also the malignancies. We have a lot of lymphomas that we can see, have the non-Hodgkin's lymphomas, which are related to HIV. Not everyone has iris once you drop your CD4 cell count, but the risk is high. If we knew what causes iris, we would be able to tell that patient A is going to get iris and patient B is not going to get iris. But we don't know what the cause is. So we only go on the level of CD4 cell count, and we are more awake, more vigilant in those patients who have low CD4 cell count, not to start them immediately on ARVs, but rather treat the opportunistic infection up to maybe 2 months or 2 weeks and so on. The dilemma here is that you may treat them quickly and get iris, or leave them and they die even before you start treatment. So it's always dicey when to start.
Deciding how to treat the patient can be very difficult, and the decision can have big consequences. To illustrate this, here is the case of an iris patient, presented by one of his doctors.
The patient, he was a 42-year-old male. He was known with HIV, started on ARVs. This was in September of 2015. The initial CD4 count was 74 cells. We saw him in casualty. He presented with a shortness of breath for 1 week, with a productive cough that was white in color for 3 weeks, but there was no hemoptysis. He also had fever for a month, and then weight loss with loss of appetite, and that was also for a month. The patient had no other past medical history. The only treatment he was on was the ARVs, but he was on a strange combination started by the private GP. He was on AZT 300 milligram, as well as 3TC 150 milligram, which is an odd combination. We don't start patients on this. I'm not sure who started him on it. Of note, he had an old herpes zoster scar on the face, which he says he got in 2011, which is probably the first time that he got, the first sign of HIV that he got was in 2011. But he had no oral candida. Chest examination, as I said before, the patient was in respiratory distress, and on auscultation he had bilateral fine crepitations that were scattered, but no wheezes. We also did LDH because we were thinking the patient could have PCP, So LDH was high, it was 480, and then the CRP was also 114. So we admitted the patient with a diagnosis of Wilquirine PCP. It was an AP view of the X-ray. It shows, if you look at the lung fields especially, it's got this ground glass appearance. This ground glass appearance is classical of PCP, but if you look closely, it's got a bit of, this looks like cavities, small cavities with a bit of nodular appearance, which would also make you think of TB. But looking at it at first glance, it's more likely PCP. He's even got fluid in the fissure. Yeah. But there's nothing really of note on the cardiothoracic ratio. So we assessed the patient as a 42-year-old male, background history of HIV, stage 4, now presenting with iris in the form of PCP, but also to exclude pulmonary TB. And yeah, that's just about it. But after admission to the ward, I think it was 3 hours later, the patient started desaturating. He developed central and peripheral cyanosis. The blood gas that was done showed that it showed signs of hypoxia, acute hypoxia. The patient then demised in the ward without having been intubated.
The patient died after getting the wrong treatment. The man got treatment for AIDS, but not for the opportunistic infection. But then how should iris be treated?
The treatment of iris basically depends on what opportunistic infection you are dealing with. If you are dealing with TB, you will treat that patient for TB. If you have cryptococcal meningitis, you will treat it. Standard treatment of cryptococcal meningitis. The only challenge here is that you have to give steroids in patients who are very sick with iris, because you'd like to suppress the immune system, which has been so vicious to the body, and then we would like to suppress that by giving steroids. So we usually give steroids in addition to the treatment of that particular condition that we have. That's the treatment of iris. And just to add to the treatment of iris is that some doctors and some workers are tempted to stop the treatment of iris because the patients are too sick, and but usually what is recommended is that you should not stop the treatment but continue and just add steroids in such patients.
So instead of immediately treating AIDS, in the first period, only the opportunistic infection is being treated. After making treatment accessible for everyone, getting the HIV infected on treatment is the next big challenge, especially since a big part of the population has other beliefs on health. What is the role of traditional medicine in all this?
That is a tricky one. That's a tricky one because our people, especially black patients, Africans in particular, in this sector, still believe in traditional medicine, and they either see the traditional healer before they see a Western trained doctor, or they see a traditional healer after seeing a Western trained doctor. So the traditional healers may delay treatment by starting their treatment first. It's estimated that in the African community, about 85% of your patient load, especially in rural areas, believe in traditional medicine, and they'll consult with the traditional medicine. It doesn't matter what the government will say, even if you can change policy and so on. The patient will still go to traditional healers because they believe that they will get help. The difference between the Western medicine and traditional healers is that a traditional healer will tell the patient why the patient is sick. Why am I having diabetes and then the next door neighbor is not having diabetes? And the Western doctor will say it's genetic, it's because your father or your mother had it, and so on, and so on. You take a long way. But the traditional healer will say you are being bewitched by the guy next door. So they tend to believe in direct answers than answers which depends on research and so on. They don't understand research. I think also the bottom line is that the more educated people are, the less they believe in traditional medicine. So in other words, you will have more people who are not so educated go into traditional healers, because that's how they can explain why they are sick quickly.
People need to believe in the treatment. But how is this accomplished?
I think maybe we can go to the primary schools to advise the children about how people can be infected to AIDS. So they will grow up knowing that AIDS, how can prevent it.
As Nelson Mandela said, education is the most powerful weapon we can use to change the world. Through education, people can be taught how to prevent HIV and AIDS and learn about the importance of treatment. It will be a crucial factor in the battle against this disease.
Uit die blauw van onze hemel, uit die diepte van ons see, oor ons ewige gebergtes, waar die kranse antwoord gee. Sounds a call to come together, and united we shall stand. Let us live and strive for freedom in South Africa.